Okay, before I start, I'm going to advance. Yep. Okay, so when I advance the slide just now, it advances for you guys?
Yes.
Okay. All right, welcome everyone to Neurology Grand Rounds. For those of you who don't know me, and for those of you who do know me, I'm Doug Gelb. I'm a general neurologist on faculty here at University of Michigan, and I'm going to talk today about the philosophy behind brain death and something called the Unitary death principle. And my question is whether it's time for us to withdraw support from those things. My disclosures are that I get royalties or honoraria from the places shown here, none of which relate to anything I'll be talking about today. Also, I've actually submitted some of this material for publication in Neurology, and it's currently under review. Probably the most important disclosure is that this is not a field in which I would consider myself an expert. I am the chair of the Brain Death Committee here at U of M, but our charge is basically to ensure that when patients are declared brain dead, that all of the institutional policies are followed, and also to ensure that those policies are in line with national recommendations. So it's really kind of a technocratic role that we play, and I'm not going to be talking about those technical aspects today. I'm going to be talking about the philosophical concepts underlying brain death. The other disclosure is, as is my wont, I will probably be kind of sarcastic about some of the people that I talk about and some of the things that people did 50 years ago and since, and I was not there in any of those discussions, so I'm probably misrepresenting them and probably underestimating some of the thought that went into things that have come before me. So these are the learning objectives. Basically, they are primarily that by the end of this talk, you should be able to define a bunch of terms that are in the literature. So brain death, the unitary death principle, the whole brain formulation, the higher brain formulation, the brainstem formulation, and you should know what are the arguments in favor and against each of those formulations. All of that is in the literature, and then what is kind of my contribution in this talk is concept regarding building a fence around the law and applying that to brain death. This is what I'm not going to be talking about. There's a lot of discussion that relates to what I just said is the technocratic role of the Brain Death Committee. A lot of discussion worldwide about the fact that there are discrepancies in policies between one institution and another, one country and another. There's debate about whether there should be one clinical examination or two, what the role of ancillary tests should be, and so forth. And there's this World Brain Death Project that about a year ago came out with recommendations for ways to standardize some of the technocratic aspects of brain death determination. I'm not going to be talking about any of that. So this is the outline of what I will be talking about. I'm going to go through a little of the history of brain death, then the philosophy behind it, the pros and cons of the different approaches, and the concerns that have been raised, and my recommendation for how we might resolve some of those concerns. So starting with the history, the whole concept of brain death really was moot until the development of positive pressure ventilation. In the old days, if somebody died, it was pretty clear. Their heart stopped, their lungs stopped, their brain stopped, their kidneys stopped, their liver stopped. There was no debate about what had happened. The entire body had stopped, and that was that. All of that changed in 1952 with the development of positive pressure ventilation. And I'm going to make a brief digression here just because this has become kind of more at the forefront since the COVID-19 pandemic began. People have harkened back to the development of the positive pressure ventilation, which was actually back in 1952. Denmark was one of the hotspots of the polio epidemic, and this in Copenhagen in particular, they were admitting 50 people a day, 6 to 12 of them with respiratory failure. 87% of the people who developed respiratory problems died, and the only real approach that was available at that time for respiratory difficulty like that was the iron lung, which for the youngsters in the crowd is a mechanical contraption that basically externally applies negative pressure. And so it's an attempt to simulate and augment the effects of the diaphragm in expanding the chest cavity and therefore expanding the lungs. The problem was that it doesn't work very well, and that there was only one iron lung in all of Copenhagen. So this anesthesiologist, Bjorn Ibsen, proposed that they try positive pressure ventilation, where instead of externally expanding with negative pressure, you put positive pressure right into the airway. They even know the name of the first patient, a 12-year-old girl that they did it with. They did a tracheostomy. They applied the positive pressure. Unfortunately, there was no such thing as a ventilator machine at the time. So they recruited ultimately hundreds of medical students and dental students from University of Copenhagen to take 6-hour shifts. And ultimately they were there for months bagging patients and dropping the mortality rate down to 31% in people with respiratory failure. I think that must have made the personal statement of residency applications particularly tedious to read that year, but all the same, it was a major advance in medicine. Ibsen is credited with the not only the development of ventilation as we know it, but the whole concept of the ICU. The day that he did this is a national holiday, I guess, in Denmark, August 27th, although some of the references I found listed as August 26th. So if you are making travel plans to go there to celebrate the holiday, you might want to check to see exactly when the fireworks are going to be. All right, so that was the first development that that kind of brought the concept of brain death into being, because shortly after the development of positive pressure ventilation, clinicians started to notice that some of the patients who were put on a ventilator and managed aggressively nonetheless developed a form of coma that Molleret and Goulon in 1959 called coma dépassé, meaning a state beyond coma in which all cognitive and vegetative functions were lost. So basically, these were patients where it was a more extreme coma, and in fact, those patients invariably had their heart shut down soon after they developed that neurologic condition. And then the final thing that raised the issue or brought brain death to the fore was the development of transplantation. Kidney transplant, the first one was in 1954, but as we all know, you've got two kidneys. It's not necessarily an ethical conundrum to remove one of the kidneys from a live donor, or you can remove kidneys from deceased donors. But then in 1967 was the first heart transplant, and obviously that raises questions because in someone who has died according to the traditional definition of death, the heart is not going to be very viable as a organ to donate for very long. And in someone who has not died, to take their heart out, they don't have an extra heart, and so it raises major ethical questions. So basically, the combination of the development of positive pressure ventilation and the ability to perform organ transplantation, especially unpaired organs, was what brought the issue of brain death to the core. And in 1968, a commission at Harvard met to try to decide how to approach these issues. And they were called the Ad Hoc Committee of the Harvard Medical School to examine the definition of brain death. They published this article in JAMA, a definition of irreversible coma was what they called it at that point. And as they stated in their introductory paragraph, our primary purpose is to define irreversible coma as a new criterion for death. And there's two reasons why there's a need for a definition. Number one, improvements in resuscitative measures sometimes lead to only partial success, resulting in an individual whose heart continues to beat, but whose brain is irreversibly damaged. So basically referring to that coma dépassé that had been identified in 1959. And number two, obsolete criteria for the definition of death can lead to controversy in obtaining organs for transplantation. Part of the reason I'm reading these quotes verbatim is that, as I'll be talking about, people have raised critiques of the concept of brain death over the years. And some of the people who have criticized the concept have maintained that really this is just a legal fiction that was developed in order to facilitate organ transplantation. And many of the defenders of the brain death criteria and concept argue, oh no, that's that's not at all what the concept was developed for. It was because of the coma dépassé and the fact that there are people who have irreversible brain damage, and it would be unethical to continue doing aggressive measures to keep their organs alive. And so I'm just pointing out that in the paper that is always cited as the initial paper on this topic, they clearly were aware of the relevance to transplantation. So it's a little disingenuous to say that that was not something they were thinking about at the time. Some other quotes, again, relevant to critiques that are raised subsequently. They talked about the fact that in somebody who is in this state, they have loss of function at the cerebral and brainstem levels, and often the spinal level. And that'll become relevant later. And then secondly, there's this long quote, which I'll just highlight the main parts, that they talked about the fact that they sometimes do have some conserved neurologic function. And they talk about this paradoxical state in which the person is brain dead, but has retained cardiovascular function to some extent independent of nervous control, despite widespread disorder of the cerebrum, the brainstem, and the spinal cord. So you'll see there, as I talked about with the coma dépassé, all of those patients originally described had cardiovascular collapse relatively soon, and at some points in the development of the brain death formulation, people have claimed that that is universally true, but even in this initial article, they recognize that no, it's not universally true. All right, so after that article appeared and various other articles appeared elsewhere, physicians started to act on those recommendations. States started to act on those recommendations. By 1978, there were 27 states that had statutes applying to the question of brain death. And the country began to enter this kind of anomalous state in which you could be declared brain dead or therefore dead in one state and not in another. So there is a sorry, I'm trying to see where I wrote this down for myself. Here we go. There's an organization which, until I started looking this up, I wasn't aware of, called the it was previously called the National Conference of Commissioners on Uniform State Laws. Their name has now changed. It's the Uniform Law Commission. But they, their mission is to try to identify issues that it would be worthwhile to have uniform laws across the country and to propose model versions of those laws. And so in 1978, they did develop a model statute, and it ultimately in 1980 became the Uniform Determination of Death Act. And in 1981, a President's Commission for the Study of Ethical Problems in Medicine and Biomedical and Behavioral Research met and reviewed the proposed Uniform Determination of Death Act and endorsed it. And the Uniform Law Commission also approved the UDDA, the Uniform Determination of Death Act. And also in 1981, that President's Commission published a short summary article in Annals of Internal Medicine called Guidelines for the Determination of Death. So 1981 is kind of the point where everything becomes more codified. And this is just that JAMA. I'm sorry, I said Annals of Internal Medicine, but it was JAMA where that article was published. And one of, and kind of the summary statement of what the President's Commission row was here. An individual who has sustained either irreversible cessation of circulatory and respiratory functions or irreversible cessation of all functions of the entire brain, including the brainstem, is dead. Okay, so that brings us to the unitary death principle. Remember, this is one of your learning objectives for this talk. Know this principle. So death is a unitary phenomenon, and it can be demonstrated in one of two ways, either the old-fashioned way of heart and lungs stopped, or the new way, which is irreversible loss of all functions of the entire brain. And obviously, somebody who's on artificial ventilation, you can't use the old-fashioned mechanism, and so you have to use the new definition, irreversible loss of all functions of the entire brain. In the president's report, actually not in that 4-page JAMA article, interestingly, but in a couple places in the president's report, they do make the point that I was alluding to earlier. They say that in those patients who have complete loss of function of the entire brain, you can continue to maintain respiration and circulation with a ventilator and intensive medical management, but the circulatory function is only going to persist for a limited time, and within 2 to 10 days, the heart will stop beating no matter what you do. It's a little bit unfortunate that they said that because they had essentially no evidence for it, and it's confused things ever since, and it's since essentially been abandoned, but it continues to confuse some of the discussions about this topic. And here again, this is the second place where they mention it. Even with extraordinary medical care, the circulatory functions can't be sustained indefinitely, typically no longer than several days. All right, so that kind of set the stage for this guy, Alan Schumann, who's a neurologist who had been basically a supporter of brain death when the concept was first developed. But with time, he started to have doubts and looked at reports that had been circulated either in the popular press or in journals of people who were felt to be brain dead, who then ended up having sustained function much longer than the President's Commission had claimed they could. And he published this article, Chronic Brain Death, a meta-analysis and conceptual consequences. He kind of went a little over the top in that he started to do survival curves and so forth with data that really didn't deserve to be analyzed statistically, but he found 175 cases in people who had been diagnosed as brain dead but had survived for at least a week. And then he said that 56 of them, their documentation was adequate to actually perform his meta-analysis. And of those, half of them had survived for more than a month, and you can see the numbers there, but the record was a child who had survived more than 14 years after being declared brain dead. All 4 of the people who had survived more than a year were young children. 2 of them had been neonates. All 9 people who survived more than 4 months were less than 18 years old. And conversely, anybody who was over 30, all of those patients survived less than 2.5 months. But all the same, he went through and analyzed these reports and said, look, this concept that once you have met criteria for brain death means that your heart is bound to fail within a week or 2 weeks or something like that is obviously not valid. And not only that, but as he looked in the reports, he found other functions that these people were reported to have preserved. And you can see here, but things like functioning of the immune system, the febrile response. There are cases where children have grown and actually shown sexual maturation. Pregnant women who have been maintained on ventilatory support and aggressive treatment have had their fetus carried to term, or at least to the point where they could be delivered, and so forth. So, so he challenged the idea that the people who met criteria for brain death really in some way had complete loss of all integrated functions of the brain, which, as I'm going to be talking about in a minute, was kind of the philosophy that had been proposed to justify the concept of brain death. Largely because of Schumann, as far as I can tell, another president's commission met in 2009 called the and they reviewed, basically the state of the art in brain death, including Schumann's claims, and they ended up first of all challenging the whole terminology of brain death. So they said it's really confusing for people. We ought to use something different. They came up with the term total brain failure, which actually makes a lot of sense, but pretty much everything I'm about to say about this President's Council on Bioethics, it was a thoughtful report, and as far as I can tell, for the most part, it's been ignored in the mainstream of neurologic practice, and certainly this idea that we should change the name never gained any traction. This loss of somatic integration that I'll talk about in a minute, they said that's flawed. They replaced it with these other things, but ultimately they said, brain death should really mean loss of consciousness and loss of spontaneous respiration. But as I say, nobody really paid any attention to that. And as far as the mainstream within neurology, mainstream establishment of people who write about brain death and develop national policies for neurologists, most of them not only ignored the President's Council, but they basically blew off Schumann's reports. They said, many of those were from sources that were very poorly documented. There's actually no proof that any of his patients had been evaluated in a satisfactory way to establish that they were brain dead, and he has been kind of a voice in the wilderness ever since, often invited to the conferences that they hold only so that they can ignore him in person. As I said, I'm probably overstating things here. All right, so what are the challenges other than what Alan Schumann has, what I've already said about Alan Schumann? So basically, even at the time that the President's Commission met in 1981, there had been several different formulations of what brain death meant. When the Harvard ad hoc committee met initially, they didn't really try to justify, or at least not in any kind of formal way, the philosophy underlying their concept. They just said, look, there are these people who have no brain function. They should be considered dead. They didn't, they went into a little bit more about how when people in the old days were declared dead, obviously they had lost all brain function in the days before ventilators. And they kind of implied that therefore the old definition of death, really what would the heart and lung function was being treated as a surrogate for brain function. But they never tried to present a systematic philosophical discussion of why it made sense to equate loss of brain function with loss of heart and lung function. But by 1981, when the President's Commission met, a lot of people had written about this, and there were three main camps as far as what should be considered brain death: the whole brain, higher brain, and brainstem. And then, as I said, there were some people who just didn't buy into the concept and said, bag it. But I won't be talking too much more about that camp. All right, so the whole brain is the one that has pretty much been the establishment formulation. And it basically takes the view that what I just said, that when in the old days, when we identified somebody as having no heartbeat and no respirations, we knew that that also meant that their brain had stopped functioning, and really that's what we cared about. If back 1,000 years ago, if we had somehow had a way to keep the heart and lungs functioning, but the brain was still not functioning, then we would have still considered those people dead. And so the brain is important not only because it is responsible for what we think of as what makes us human, our consciousness, and our higher cognitive function, but also because it actually is coordinating all those other functions in the body: the spontaneous breathing, circulation, many endocrine functions, and basically all of those subsystems that are responsible for integrated function of the body are coordinated by the brain. And so if you have lost function of the entire brain, you have essentially achieved the same state as the traditional state of death, even if we are artificially ventilating. But specifically, they said it's all of those critical functions are important. So they did address the fact that somebody might have complete loss of consciousness, but if the brain still had the power to coordinate some of those integrated functions, then that person could not be considered dead. And that'll come up when I talk about the higher brain formulation and the objection to that. But they very specifically were arguing against the idea that all that matters is consciousness. The higher brain, so anyway, probably the person at the time most associated with this philosophical formulation of whole brain is Jim Burnett, who was at Dartmouth. Burnett, Culver, and Gert in 1981 published a very influential paper that was called On the Definition and Criterion of Death. In a summary that Burnett wrote in 1998, he said, "Death is permanent cessation of functioning of the organism as a whole." But you can see the words he used there to explain what he meant by organism as a whole. And he said that the brain coordinates all those functions. And so it makes sense to say that when the whole brain has ceased to function, that the person is dead. By 1998, though, he recognized that actually some patients who meet criteria for brain death do not develop diabetes insipidus. Some do, but most do, but some don't, in suggesting that some patients actually are still secreting antidiuretic hormone, which we know is from the hypothalamus, and so he kind of had to do a little bit of backtracking on his original expression of his theory, and said, well, it's not all integrative functions, it's the critical functions of the organism as a whole. And then he went on to say what those were, and so those were breathing, circulation, and the functions that are necessary for homeostasis, but apparently, maintaining fluid balance is not considered critical. And consciousness obviously is included, but is not the only critical function. Okay, the higher brain formulation is obviously what I've just been contrasting the whole brain formulation with. It's the idea that if somebody has lost what is essential to personhood, then they are dead, basically. And what is essential to personhood, it's well, that's where this formulation starts to run into problems. Is everybody has slightly different terms. Some talk about self-awareness, some talk about reasoning and cognition, some talk about feeling. All of them pretty much include consciousness, but some go beyond consciousness, some just specifically talk about consciousness. And I'll get into the pros and cons in a minute. The brainstem formulation says, you know, if you look at the people you guys are declaring brain dead, whether you're whole brain or higher brain, well, basically the whole brain people. If you look at those, you know, the patients who have loss of all brain function as they are defined in any criteria, what you're really doing is you're looking at a lot of brainstem reflexes, and you're looking at them in a patient who's unconscious. And in fact, the brainstem also mediates consciousness because the reticular activating system is located there. So really, it's not the whole brain that you care about, it's just the brainstem. And so, and in fact, this is the basis of the legal formulation in Great Britain, is that brain death is the loss of brainstem reflexes in an unconscious patient. Okay, and as I said, some people, especially after Schumann published his article, said, you know, this whole brain death idea is too flawed. We should eliminate or just trash the entire thing. All right, so what are the pros and cons of these things? Well, the whole brain formulation, as I have already said, there's kind of been a gradual erosion of the way it's been stated, because even at the very beginning, people realized, well, you could probably have a few neurons that were still alive, and that wouldn't really change the fact that the brain was not functioning. Maybe even some islands of neurons. So they almost from the start said, look, it's not specific structures are dead, it's the loss of all brain functions. But then, as I said, over time, they realized, oh, you can end up with some endocrine function preserved. So then they changed it to the loss of all critical functions. And then, you know, Schumann's cases suggested that you could actually have a lot of other preserved functions. And the response to that was, well, we don't believe Schumann's cases, basically. So that's one set of problems with the whole brain formulation, is what do you mean by whole brain, since you've admitted that you don't mean every single neuron, and then you kind of keep changing, you know, each time somebody says, oh, here's an example of something that is sometimes preserved, you go, oh, well, that wasn't a part of that, isn't a critical function of the whole brain. The other one, I gave that quote early on about the spinal cord is usually affected also, but the criteria never actually have required that there be spinal cord death, which has raised people or caused people to ask the question, so why is it that the corneal reflex is considered a critical function and the biceps reflex or the pectoralis reflex is not? And the people who support the whole brain formulation have various arguments for that, though they are not particularly convincing. And then Burnett in particular, much of his writing has really seemed to, it seems like a major motivation all along has been to try to figure out a way to define brain death in a way that it will seem like it's consistent with the traditional way we declared people to be dead before ventilation was available. And he has various arguments, as I said. He talks about the critical integrating function of the brain and how it is, when you've lost the brain function, you've lost your systemic functions also. And he therefore says, so that's really what people meant back when they went up to somebody and put a mirror in front of their mouth and said, oh, there's no breaths, and they felt their pulse and there's no pulse. Although if you ask people, and people have actually done studies, even in the modern era, when people have gone to medical school, learned about brain death, and ask them, well, is brain death equivalent and identical to cardiorespiratory death? Certainly the population at large doesn't see it as equivalent, and even medical students, doctors, and even ICU doctors often can say that they don't see them as equivalent. All right, as far as the higher brain formulation, the main problem there is that the slippery slope thing. All right, so if you're gonna say, well, what makes us human is the ability to reason, then what about somebody with advanced dementia? What about somebody who has a congenital severe impairment in cognition? And most tellingly, what about a persistent vegetative state, in which the person, at least many people who are deemed to be in persistent vegetative state, as far as we can tell, have absolutely no consciousness, no higher cortical functions, but they may have actually recovery of their respiratory reflex, and they may be able to breathe on their own. They have independent circulation and a sleep-wake cycle. And so if you're going to define death as the loss of higher cognitive function, then a person in persistent vegetative state would be dead, and yet they're breathing and their heart is beating. And it feels a little bit weird to say, well, that person is dead and could be buried. So if you're gonna maintain the brainstem formulation of brain death, you are either gonna have to tell Doc to declare Snow White dead, which is gonna make Happy and Bashful very upset, or you're gonna have to abandon the unitary death principle. And in effect, accepting the brainstem formulation means you have to abandon the unitary death principle. The other issue is same thing. If you talk about brain death means loss of higher cognitive function, then you can't really talk about brain death equals death, because what about species that don't even have cognitive function? And so then you've got to say, well, death is something different across species, and that seems kind of weird. All right, as far as the brainstem formulation, that one actually is not that bad, except that there's the question about, could you sometimes have a person who is basically in a super locked in state? And I know of at least, I know of one situation here where a patient was being operated on for a posterior circulation aneurysm, unfortunately bled, had massive damage to their brainstem, and was being considered for brain death. But actually an EEG got done, and they had essentially an encephalopathic EEG, but there was still organized brain activity. It was not at all questionable. And so in a person where the primary damage is to the brainstem or to the nerves exiting the brainstem, so somebody with really bad Guillain-Barré syndrome, somebody with a really bad meningeal process, there's the potential that you would then mistake that person for having no higher cortical function, even though they actually do. It's just you can't access it because all of the neurologic mechanisms that we usually use to express ourselves are non-functioning in that person. All right, I think I actually can do this without talking about Jahi McMath, but the case of Jahi McMath, many of you have probably heard about it, that kind of brought a lot of these objections to a head, to the point where between that situation and other legal cases that have been brought around the same time, and the concerns about endocrine function and lack of standardization and so forth, people are actually suggesting that the Uniform Determination of Death Act be revised. And in fact, the Uniform Laws Commission has appointed a study group to try to decide whether or not to revise the UDDA. But here's my suggestion for how we go about solving it. And it stems from a concept in the Talmud, which is pretty much all I know about the Talmud, but it's called build a fence around the Torah, the law. So build a fence around the law. And the classic illustration that's always given is that there's a biblical injunction against eating a kid, a baby goat, in its mother's milk. And the rabbis thought about that and argued, well, you know, how do you know that it's that whether it's the kid's mother or not? So so it should be, you shouldn't eat any goat with milk. And then it was, well, how do you even know if you're eating the meat? It's kind of hard to tell one meat apart from another. And so, or rather, you shouldn't boil it in the milk, right? But then the thought was, well, you know, in your digestive system, you're kind of boiling the meat there. So not only should you not boil it in milk, you shouldn't eat it in milk. And then because, you know, you can't know exactly where the meat came from, better not eat any milk within a certain number of hours of, better not eat any meat within a certain number of hours of having milk. And that's where the prohibition against eating milk and meat comes from. So it's a much broader prohibition than the original act that was proscribed. And so the idea is you've got a certain thing that you really want to be sure you avoid. In order to ensure that, you build a fence around it and you prohibit people from transgressing that fence. And even if sometimes they do wander into the fence a little bit, it's so far out that at least there's no risk of committing the original prohibited act, which is what you really care about. So I have what I'm calling here the shielded brain formulation, where I'm defining brain death as the irreversible loss of consciousness, but I'm saying the declaration of brain death can only occur in the situation where not only is there irreversible loss of consciousness, but all brainstem reflexes are absent, and the condition that the person has is known to affect both the brainstem and cerebral cortex. So statement number one here, I've lost my pointer, is conceptually the higher brain formulation, which to me is the one that actually makes the most sense. But operationally, it's identical to the whole brain formulation. That's statement number two. And that's the fence around the law, basically. So the law here is loss of personhood constitutes brain death. But because personhood is so difficult to define and identify and test for, the first expansion of the fence is I'm changing that to consciousness. So the person has to have irreversible loss of consciousness. And then because, especially in recent years where people have maintained that there's something called covert consciousness, and it certainly can be difficult to tell in these patients whether they're conscious or not. We expand the offense further by saying the person also has to have loss of brainstem reflexes. And then because of the super locked in concern with the brainstem formulation, we expand the offense further and say, you've got to know that the underlying condition is one that affects both brainstem and cortex, which therefore would rule out that example I gave of the person with the severe brainstem hemorrhage. All right, notice that in this formulation, you could, in principle, define brain death the way I just defined it. You could say that is the same as death, but it just seems for the same reason that when they do surveys with the current system, nobody seems to really accept that at an intuitive level. I think we should just trash the unitary death principle and acknowledge that somebody who meets those criteria for brain dead, they are not the same as somebody who is traditionally dead, but they should be considered eligible for organ donation. All right, so if I look again at all of the objections to the traditional formulations, you know, all the preserved areas of function, those first 3 rows, that's not a problem with the shielded brain formulation because there's no claim that brain death is loss of the entire brain function. The question about, you know, why do we include the brainstem reflexes but not the spinal cord? Well, it's because operationally, the shielded brain formulation is identical to the whole brain formulation that has been in practice for 50 years now. And there's no documented case of anybody who met brain death criteria according to that formulation ever having recovered consciousness. Schumann's cases, none of them recovered consciousness. And that's where people can ask me about Jahi McMath in a minute. The business about consistency with traditional notions and across species and so forth, because I've abandoned the unitary death principle, that's not an issue anymore. And the whole slippery slope thing, that's the whole reason that I put the fence in place. So I maintain that this formulation actually sidesteps all of the concerns that have been raised with the traditional formulations, which I put in pink exclamation marks in this slide. All right, so the conclusion of the lecture, there are legitimate objections to the traditional formulations. The shielded brain formulation that I'm proposing operationally is the same as the current practice, so it preserves that, but it resolves the conceptual issues that are inherent in the traditional formulations. It seems to me way more consistent with intuition. There are loads of situations in everyday life where we build a fence around a concept. My dad's mantra was always leave a margin for error. As physicians, we are well aware of the trade-off between sensitivity and specificity. And so we're used to recognizing that sometimes you need to sacrifice sensitivity in order to be as specific as possible. And that's essentially what I'm doing. And most important, well, also important, is that by disentangling brain death from death, then the situations in which a person meets criteria for brain death, but the family objects to the concept, there will no longer be this this idea that, well, the patient is dead, that then leads the medical staff to feel morally outraged at the fact that, you know, every passing moment that we are continuing to keep the ventilator running or, you know, giving aggressive support, you know, is maintaining a corpse. Instead, it's basically, that's a situation in which we acknowledge that the prognosis for meaningful recovery is 0, but it will become less emotionally fraught. I think it might be very appropriate for hospitals and insurance, private and public, to say, look, in a situation like that, we're not going to pay for this care, but at least it won't be as likely to lead to these huge fights between families and advocacy groups and the medical system because you've kind of toned down the emotions. And those were my learning objectives again. I will stop with 4 minutes for questions. Catherine asked a direct message. So if you separate brain death from death, how do you then justify the donation of necessary organs from a patient who is not dead? I justify it because that person has lost all of what it means to be a person. And I think it is, we certainly would have no concerns about withdrawing support from such a person. So if their wishes were to donate their organs, the whole reason that there's a distinction between withdrawal of support and the standards that have traditionally been used for organ donation is, again, the slippery slope thing. You don't want to get in this position where you're trying to use society's gain as a basis for stopping the ventilator in somebody with who actually has some level of function, even though it might be less than what you consider important function. But in a situation where you specifically have said, look, these are the very specific criteria that have been shown over 50 years to correlate with no chance of recovery of consciousness, I think it is ethically permissible. Somebody wrote something about, whoops.
Can I ask whether you're planning to present this to a hospital-wide audience or obtain from the hospital any kind of approval process?
Well, so as far as the policies, the actual mechanics of declaring brain death, my approach is not changing that at all. So it wouldn't actually change any of our policies, other than the fact that in the policies we do say that there are, we kind of allude to the Unified Declaration of Death Act, and so it's changing the philosophical underpinnings, but it's not changing the mechanics. I've written this up as an opinion piece, basically, for the journal Neurology, and it's currently at the stage where I have responded to reviewers, and I'm waiting to hear if they consider my response acceptable. Once I hear from them if I hear from them that it's accepted for publication, then once I hear that it's okay to do so, I plan to send a copy of the manuscript to every member of that study group of the Uniform Laws Commission, and see if I can get them to pay any attention to me before they do their final deliberations. Looks like Pat says, how would you apply this to anencephalic infants? I guess it would be I'd have to think about it. That if they, but my gut feeling is basically if they meet criteria for brain death the way they are, the way the criteria are stated currently, then they will still meet those criteria under this formulation. So I wouldn't be changing anything from however we treat that currently. Larry asked me explain shielded. I spent a ton of time trying to figure out the best word here, but essentially I just mean that you're trying to protect the core, which is personhood, with something that's kind of external to it, like a shield. Alyssa says, I'm wondering how personhood and consciousness are defined in the case of infants. And I guess my answer is similar to my answer about anencephaly. Would all donation then have to be DCD since we would not be able to declare death on neurologic criteria? No, I'm saying you would still be able to declare death on the basis of circulatory and respiratory cessation. But you would also, and then you could donate organs from someone who is dead, but you could also donate organs from someone who is not dead, but who meets criteria for brain death. Okay, I think that's all the ones that were in the chat. Anybody else want to ask me something, even though we're out of time?
Doug, this is Darren, just to follow up on that DCD issue, then, would you propose that then that those people who meet the criteria are in fact dead? You're just removing the distinction that the two forms of being declared dead are equivalent.
No, I'm saying that they're not dead. I like the fact that the President's Commission or the President's Council at one point suggested getting rid of the term brain death. I think we should just define this condition in which, there is no chance of recovery of consciousness, and, call it sadness or something. And someone who meets criteria for sadness, it's also ethically permissible to donate organs from someone like that, even though they may not be dead. Now, the fact is they will be dead as soon as you take them off the ventilator, because that's one of the criteria, is they have to have no respiratory reflex. But, personally, I wish we had a different name for it and just say, we've got these two things that make it permissible to donate organs. One is death, one is sadness. But I don't think that's ever going to happen. There's, so many years of people talking about brain death that I think we're stuck with that term. Somebody just put, oh wait, there's a couple things. Oh, well, never mind. So I personally agree about your interpretation of the ethics of donation in these cases, but my concern is that the lack of declaration of death would lead to complicated grief for families, as donation would then be killing the patient. I guess I don't really see that, because there are plenty of times where we withdraw support from people now that we don't consider dead. And as long as you explain it to patients, I think it's, they accept it and agree with it. Rafi says, hi, Rafi. Your cardinal rule about declaring brain death was to declare it, 1, for organ donation, and 2, if there is conflict between family and team. With your definition, we should diagnose whenever it's present, right? All right, so I guess we still should declare it if you're thinking about organ donation, because the organs are most likely to be viable if you do it while you're still, you haven't disconnected the person to see if they meet criteria for death by cardiac criteria. As far as bad prognosis, yeah, I mean, I think it becomes less important to go through the whole rigmarole if you've already got a situation where the medical staff and the family are pretty much on the same page that the prognosis is poor. I don't really see that you need to go through all of the steps of proving that they meet the criteria for what I'm now just, as of 10 minutes ago, calling sadness. And in fact, I guess I would still maintain what I always maintained, that, you know, then what if you find that there's a corneal reflex, you know, and then you've got everybody sort of hanging their hat on, oh, did they meet these criteria or not? So I would still say no. The only real reason to declare, to go through the process of declaring brain death is if you're thinking about organ donation. It's just now, it's less important to do it from the standpoint of disagreement with the family, because even if they do meet criteria, now I would say you'd be taking a softer stand. I would say, you know, it would be good to go through that process, because then you can feel confident in saying to the family, you know, there has never been a situation where there was documented recovery of consciousness in a person who was in this condition. But I would still say at this point, you would then defer to the family, unlike our current situation where you then call, you know, the ethics committee and the lawyers and so forth, because you're saying, we've got to stop this. You know, now you would say to the family, we strongly recommend that we stop this. And in fact, your insurance is not going to be paying for this anymore, but you wouldn't be fighting with them in the same way. I hope that was clear. I'm now 7 minutes over time. I can do this all day, but I think we should probably stop. All right.
Thank you, Doug. That was really great.
Thank you all.